Great. So I'll just say that we. Ladies and gentlemen, welcome to Talking TB, the road to 2030. We're about to get started, so if you'd like to help yourselves to a coffee, come and sit up at the front, close to the action, and we'll be back with you shortly. Thank you very much.
I know. Of UNGA programming. I'm Anna Gavell, Devex's managing editor. For this session, which is co-hosted by Stop TB Partnership, obviously we're going to be focusing on tuberculosis. I think, a running theme that we've heard all week in every discussion on global health is the sad truth that most deadly diseases in the developing world are largely preventable. That, of course, includes tuberculosis, which kills about 1.5 million people each year. That makes TB the second most infectious disease worldwide after COVID-19. And the pandemic, of course, has set TB progress back by years, with deaths increasing in 2020 for the first time in a decade. The issue was thrust into the spotlight yesterday with the Global Fund to Fight AIDS, Tuberculosis, and Malaria replenishment, where it received just over $14 billion in pledges. That was shy nearly $4 billion of what it had requested. So it's yet another sign that there's a long road ahead from 2018. That's when the UN General Assembly held its first ever high-level meeting on TB, which produced some ambitious targets by the end of 2022. That includes treating 40 million people with TB and boosting overall global TB investments to $2 billion. But these goals and many others have not been fulfilled, and the deadline is fast approaching. So today, as I mentioned, we're joined by our partners, Stop TB Partnership, to examine what needs to happen in order to hit these goals. And I want to thank also our audience, who is both here in person in a bit rainy New York City, and those virtually, hopefully sitting comfortably from their home and their office around the world. And so we're going to kick off right now with our Executive Vice President and Executive Editor, Kate Warren, who will have a fireside chat on what TB survivors want. Thank you, Kate.
Well, I would like to welcome onto the stage Dr. Luchika Ditsiu, who is the Executive Director of the Stop TB Partnership, as well as Jackie Quinn, who is from We Are TB. Thank you both for joining us today. An important conversation. So, Jackie, I'm going to start with you, but it's my great-grandmother died from TB when my grandfather was 3 years old. And in his long 94 years of life, it was really the great sadness and trauma that he really never got over. And I think what was so traumatic for him is having his mother kind of ripped from him at such a young age, sent off to sanatorium, and knowing that she died completely alone without her husband and child. And it was a sadness that it never went away. That was about 100 years ago. And as Anna set the stage. TB is still here, and we're still seeing deaths. We're still seeing treatments in a way that is not necessarily supportive of the patients and their families. You have had an experience with TB. Could you talk a little bit about that story and what you wish the health system could have provided to you mentally, physically, to better support you?
Right. So, hi everyone. Thank you for listening. Yeah, that story is very touching. Yeah. So my story begins unfortunately, like many others, which it starts with diagnosis. So you go in circles trying to find out what it is that's wrong with you, because it masks itself as a common cold. So, for the longest time, I thought that's what that was. And tuberculosis wasn't really on my radar. It really was a suggestion by close family members of mine who are physicians in Mexico. I am from a city that sees a lot of tuberculosis. And I'm from Tijuana, Mexico, right on the border with San Diego, California. However, in San Diego, people in general, myself included, and other clinicians don't seem to be very aware of that. So I do think, what we need is a lot of awareness for the public and for medical practitioners and healthcare workers, because, like I said, it took close to a month to figure out what it is that I was going through. And the infection grew during that time. And even when I was hospitalized, I was having side effects from the medication, and I could see the nurse getting scared in front of me. And, you feel like you're in the wrong hands. And, typically I don't mind. I am in the science world, so I don't mind if people, rehearse or they're practicing with me. But with tuberculosis, it's a little different, I think. And I didn't want to be, especially at that vulnerable time, I didn't want to be, a lab rat,
Yeah. And so did you feel that there was more of a stigma wrapped up into it because there is a lack of education and understanding about tuberculosis?
I actually didn't really experience any stigma. I know there's stigma in other countries. In Mexico, there's a little bit more of a stigma because it's considered to be like a low-income disease, which unfortunately it is. So people don't really like to talk about it as much. But I think on this side of the border, my experience was mainly just a lack of education, a lack of awareness and education.
Okay. And how has that inspired you to pursue advocacy, activism in this space?
I didn't really think about it, I guess, until I was going through so many different stages in my TB journey. But so some hospitals have roles that are called something along the lines of a patient navigator or something like that. So for me, I kind of wanted to be a patient navigator on the support side. So even though I always clarify, I'm not a medical practitioner, I'm not a doctor, I'm not a nurse, but I can tell them about my story, and they can, choose to take what they will from that. And now that we have an advocacy group, so I am a part of an advocacy and support group called We Are TB, and we have so many stories. Everybody's from so many different backgrounds, not only from the United States. So we all have a little bit to give to that, and people, you can relate a lot in some ways, and in some others you just learn a lot from other cultures and experiences.
That's great. And so Dr. Itu, Anna mentioned the Global Fund replenishment happened yesterday, falling short of the 18 billion, but still the highest ever. How do you think it went, and what do you think that means for TB going forward?
Yeah, so thank you so much. I really love this venue. I hope you guys have time to enjoy it a bit. If I cough, it's not COVID, but it might be TB because I am infected with TB, and you never know with the stress and stuff like that. But it's a good example of the fact that behind a cough can be many other things, and we should not do things just in parallel. I just want to preempt the fact that if I have an access of cough, is not COVID, and I'm not spreading it that easy. It's due to the air conditioning. Global Fund replenishment. After this nice introduction about cough, the target was very high, but was very high constructed, having in mind the needs to really make a difference and end these diseases. I think it is remarkable. It's 14.2 without the pledges of two important countries, especially one of them UK and Italy. So my humble predictions will be that we will probably see an additional 1 billion added to that, which will make it around 15 point something. It's still the highest ever replenishment of the Global Fund in a time in which, let's admit, the entire planet is faced with things that we've never had before. So I don't want to enumerate. When we say what's happening now on the globe, we all have different images going to our heads. However, and I want to be very selfish and unpleasant, when we speak about TB, this potential 5.2 billion, let's say 1 billion extra, will take us with some more money, but it's falling far short for what's needed. Now, even with 18 billion, we would have been falling short. But 15.2, or when you look, I think TB will get around 150 million extra. And that is giving us around 850 million per year, maximum, from the Global Fund. The the important point that we need to have, which is even if the Global Fund was replenished with 18 or 20, is that the model for the Global Fund replenishment, the so-called investment case, was constructed on TB, having in mind the global plan that Stop TB developed based and working with our colleagues from WHO and partners on the NTB strategy, which is an investment case. And then Global Fund took all these plans made by Stop TB, UNAIDS, RBM, based on the WHO strategies, computed everything, and said, this is what Global Fund should raise, but, and then here comes the but, the domestic should increase dramatically. So the challenge is now, not only that there is some extra, but not as much as we thought, but the domestic investments need to increase dramatically. And in TB, it should be at least 3 times. And I am very honored that we are sharing the day today with the Honorable Minister Leah from Ethiopia and with the Honorable Minister Joe from South Africa. These 2 countries are actually the best examples in the region in terms of domestic investments in the TB response, because in the rest of the region, unfortunately, the domestic funding in the TB response is in percentages, single digits. Below 10% of the TB needs are covered domestically. And then you have a little bit of the Global Fund, and the rest is a gap. So I think it was remarkable to see that the leaders, in a time in which they have COVID, war, energy, climate, a lot of food crisis, came up yesterday to commit and to increase, most of them, for health, basically. What is a lot to do, and that will be the biggest fight now, is increasing the domestic resources. And how? Because on their turn, the countries don't have unlimited money.
And Jackie, so talking about gaps, there's financing gaps, but what gaps do you see between what donors and policymakers are doing about addressing TB and what TB patients really need?
Meeting the actual funds asked for. Because as Luchika pointed out, it seems like we're asking for pennies and we're not even getting that. So, it would be great if they could, invest in that, because it's been 100 years. Like, how much longer do we need to wait? It really is unbelievable, especially now that we can compare it. Like, if there's a silver lining with what's been happening in the last couple of years, is that at least we have this measure now that we know things can happen quickly when there's effort put into it and money put into it. And, we don't only need it. We advocate a lot for a TB vaccine because obviously prevention is very important, but there are already so many people infected, and what's going to happen to them if the vaccine can't work? So they also need to invest in education materials and better treatment that can be accessible and that will be sustainable for hopefully less than 100 years to come.
So next year, there's a high-level meeting on TB. So Dr. Ditsu, what do you hope to see on the agenda? And do you hope that that is going to be a galvanizing moment for seeing some of these commitments? And
Yeah, I think that I'm happy Jackie is here with me, and I'm happy of We Are TB and the many other groups of survivors, but also the fact that we have a pretty wide range of partners, and some people I know for a long time, some I don't, which I find it very encouraging that there are new faces and we don't practice to the same choir. I think the only answer, and I believe very blunt here, is we need to raise hell. Because as she said, for too long, we accepted crumbles, as you said, right? And I'm sorry, but I think being polite and delicate, it doesn't go too far. And it can be hell for a global level, but a lot at country level with the people that are affected by TB that should demand things that we actually these days we give to people with TB in countries that none of us will take, okay? And no other disease will accept. We have 2/3 of the people with TB that are diagnosed with smear microscopy and clinical. None of you, none of us will accept that you go there, you get the guy with the microscope, or even worse, a clinician. You look a bit pale, I think his tuberculosis here is the treatment. When we have a golden standard recommended by WHO, the rapid molecular diagnosis, and we have manufacturers. We have X-ray that is mobile, with artificial intelligence, you can do and screen an entire village in a day if you are well prepared. We should not, we saw with COVID, it's possible to get a vaccine in less than a year. It's possible for the so-called poorest country to get live data about COVID every day that you can then tailor your interventions, or you can see. Why that is not possible for TB? It's possible, but I don't think we want it. So I think I'm happy. There are several other advocates and activists here. So what I hope to see are three things. One, an incredible mobilization at country level and regional as well as global, but that's where the root is. Being ruthless, not in attacking people, but in demanding for everybody to have access to the best tools. A unified TB community, because sometimes it's not just for TB, it's the same in HIV and malaria. Initially, I thought that it's just in TB that there are nye. No, it's everywhere. The older I get, it's everywhere. But we need in TB to stay united. Let's don't kill ourselves there. So it's with Global Fund, with WHO, with the donors, with the private sector, with the technical partners, with the civil society. Now we need to be united. So I want a united front. And the third is this. We want a very strong political declaration with very clear targets. But to happen that, we need to have two very strong co-facilitators. Yesterday in the plenary of Global Fund Replenishment, Indonesia Minister of Health said, we want to be one of the co-facilitators. And Indonesia is an amazing country. So I think if they are one of the two co-facilitators, let's see if there are other countries interested or how it goes, because it's not a decision taken by the replenishment. But we need also the meeting to happen in September 2023. There are some pushes that maybe it's happening in June. We should never, some of you, if you meet anyone and somebody says June 2023 for TB, you literally say, or maybe you physically attack them, you say that's not an option for us, because we need to have the visibility with the heads of states, and in June we will not have that. Yeah. A part of this, the only last point that I want to make is that what worked very well for the previous declaration, because it worked, is that we had numeric targets. We were not speaking butterflies. You know, you can have these UN documents that are like 60 pages in which you don't understand anything. It was very concrete, said, find 40 million people and put them on treatment. And then we unpacked that per country and we said, this is the share, I'm Romanian, of Romania. So if you want 40 million to do, you Romania, you need to find your share, 10,000 people. Yeah. How far are you or how close? So that's my dream for the UNHLM. And I think because I get old, but I'm so happy that I never met Jackie. We have so much energy. I think that's what we should aim for in 2023 and nothing less.
Great. Well, thank you, Dr. Ditsu. Thank you, Jackie. And we will dig into this more in the rest of the program. Thank you.
Kind of a country-specific view of the fight against TB. I want to welcome up our next two panelists to the stage, please. Should be working. So today we have Dr. Joe Fala, who's the Minister of Health for South Africa, and we have Dr. Leah Tadesse, who is the Minister of Health for Ethiopia. So thank you both so much for joining us. Minister Fala, I wanted to begin with you. Where is South Africa on its TB goals, and what kinds of interventions have you seen successfully reduce the incidence of TB? And on the flip side, are there any failed interventions that you've learned from?
Well, let me start by acknowledging that we have made a lot of progress right until the advent of the COVID pandemic. Still not enough in terms of reaching out, making sure that we can screen enough people, be able to have a full picture of the prevalence, do enough testing. But working together with our health professionals, civil society, we put the structures under the South African National AIDS Council, which also looks at TB and sexually transmitted infections. And over the last 2.5 years, most of that was derailed, especially during the hard lockdown. So we lost quite a lot. I must say, we acknowledge that even before that, in terms of, as I've said, we're not yet at the right targets in terms of reaching, making sure that along the 90, that 90% of people, who may have TB know their status and are on treatment and can be cured. We're still having a lot of, drug-resistant TB also growing, but the pandemic actually clearly pushed us backwards. But once the level of the pandemic went down, we have reorganized ourselves, got back together, and we quite recently approved our recovery plan. And just 6 days ago, last week, from Tuesday to Friday, we had a national conference where all partners were recommitting to their roles. From the government side, making sure that we can avail the necessary resources, financial. As Lushika has indicated, we fund up to 72% of our TB response from our domestic resources. We made, from the government side, making those commitments. The professionals, the scientists were there to up the research. The communities, organizations were there also to help us, to go out and do further screening and put people on be able to avail the modern available tools. And part of what we said was that TB and HIV lost to COVID, but COVID gained from some of the work which we had already done. We used all that experience, and we said now it's the time for COVID to pay back to TB, because we must use all the energy of fighting COVID now to fight against the TB.
Thank you. Minister Tadesse, so likewise, can you talk about your government's efforts to reduce TB in your nation of 115 million, including in the north, where the current conflict has hindered access to healthcare for about 6 million people?
Thank you. Yes, well, reducing TB incidence and mortality has been one of the biggest focus areas for our ministry and the government of Ethiopia. And with the MDG, the 15 years, we've had a reduction of mortality of around 60%, achieving those targets by primarily focusing on access to care at the primary healthcare level from our community health workers, but primarily in decentralizing diagnostic and treatment services in the primary care system, including our hospitals. And mortality, incidence even between 2015 and 2020 has also reduced by around 34%. And we recently, in 2020, we actually were out of the MDR high burden countries by the expansion of lab drug susceptibility testing and also treatment facilities for MDR. However, the big challenge is we're still not detecting a large number of cases with TB. Just this year, we have raised from about 72% to around 81% now of case detection rate. So, but we're still not detecting close to 20% of those affected by TB, and that's a large number. So to really improve that, we have been also focusing on different approaches, of course, but particularly enhancing community-based detection by empowering the community health workers to detect cases, but of course link them with the different level of cares to be tested and treated. But that has been one of the big challenges still that we are facing.
And now just to follow up, because Minister Fala had brought it up, how has COVID, and then of course, the conflict that's happening, how has all of that combined over the last several years impacted your efforts?
Yes, the pandemic and also the areas affected by communities, areas affected by conflict have been most affected by in different health issues, of course, and one being TB. Of course, within the pandemic response, and after a few months, we actually established another task force that in parallel works on continuity of essential services while we respond to the pandemic. So there was an active engagement of ensuring that, for example, patients like TB and HIV, they are not lost to follow up, and there's phone consultation, phone follow up to make sure that they're coming back to care, and also taking multi-month dispensing. So those interventions have helped us reduce the disruptions, and also particularly in conflict affected areas, we were sending mobile health teams and also for displaced populations, temporary clinic establishment, and ensuring medical supplies, TB drugs, HIV drugs are sent to areas where government cannot access using our development partners and humanitarian response partners. So those combination of these activities have helped us reduce the disruption, but at the same time, there are also interventions that within the pandemic, although it has been a challenge, it was an opportunity. For example, now we are expanding molecular testing, rapid molecular testing with gene experts, but not just the expansion of the diagnostic facility, but ensuring that it's also connected through technology. Digitization is one key aspect of COVID pandemic that is really pushing things forward. So recently we have connected we have around 324 facilities which have gene experts. So now we have connected them with this a new software which enables optimization of care, and the results being sent to patients, sent to physicians and or other care levels of care providers, enhancing the utilization. So it's not just having the diagnostic, but how we use it. So we're seeing those having a better impact in the way forward.
Thank you. Mr. Fala, so South Africa and many nations have benefited greatly from PEPFAR, from the Global Fund. At the same time, as you've seen, the pandemic has exposed the dangers on relying on wealthier nations for vaccine supply. So this, of course, gets to the growing focus and development on localization and self-sufficiency. What are your thoughts on this localization push, and what local efforts have you seen increase in your country in the fight against TB?
Indeed, we've learned a lot during as a result of COVID. Just some of the still relevant, personal protective equipment. We struggled in the beginning of COVID, and remember, in terms of infection prevention and control, those are still relevant. So following that, just as an example, there's been a huge ramp up of local production of quite a number of companies now are producing the PPEs locally. From diagnostics, we're still far short in terms of locally produced diagnostics. There are a number of companies, PCR, there's one of the local companies based in Cape Town which has produced a PCR test which is fully accredited, which is functioning. So there's progress in that regard. In as far as therapies is concerned, we still a little bit short. We do have companies which are producing a number of therapeutic, drugs. Unfortunately, a lot of them still depend on active pharmaceutical ingredients, which are imported. But at least, I'm sure many of you would know one of the big companies which has become global called Aspen Pharmaceuticals, which is producing quite a number. But of course, as I said, both in terms of HIV and TB, there's still a lot of dependence on imported active pharmaceutical ingredients. In the area of vaccinations, of course, as I said in the conference, a number of our scientists are working very hard together with their global partners, looking at the wide variety of progress which is being made, hopefully again inspired by the rapid production of COVID vaccines. That if COVID could do it, why can't TB do it? To produce a vaccine within rapid period. And of course, the messenger RNA technology, it's also giving us a lot of hope. And as you would know, that we're very grateful for the collaboration with the WHO in establishing an mRNA hub in our country. And there's a lot of optimism that through that we could be able to speed up the production of better therapies, shorter regimens of TB treatment, and also including vaccination. So across the board, there's a lot of push to say we can't continue to depend on the developed north. From the south as well, we must build our capacity across all the various intervention strategies.
Okay. Now, Minister, today's is similar. What localization efforts have you seen in Ethiopia? And what are your thoughts on this, general localization rhetoric? Do you think it's been translated into action?
Well, in terms of we're talking about local solutions, not the financing aspect. So no, I think it's not enough is not yet done to really bring context-based solutions, and that's an area where we need to do more, because in some of the country contexts, types of diagnostics that are need to be really context specific. We have tried some. For example, we have a lot of pastoralist communities who are mobile. So mobile TB clinics is something we are trying in few areas. We have yet to see the outcomes, but also, as I mentioned earlier, really how best to use community-based detection is one thing, and also expanding the different technologies. But also the access to drugs, it's really highly dependent on how timely we get them from the different countries that are imported, which should be now expanded globally. And there's always a procurement process for TB drugs is always a big challenge for us. So I think these are areas where probably big investments on health system strengthening need to support on the way forward, especially with investment through global fund and others, to ensure that countries have this health security aspect that cannot be disrupted with different challenges.
Now, quickly, just to wrap up, a twofold question. What are your thoughts on the Global Fund replenishment that happened yesterday? And what would be one call to action you would like to see after UNGA wraps up?
Well, we're very hopeful about yesterday. I know that the target was $18 billion. If I'm not mistaken, at the end, they said it was 14.2 billion. But it looks like there's still hopefully, some big hitters who might still come to the party. We hope that even if it's not immediately reach the 18 billion, but very close to it. We, as a country, I'm sure all of us as the African region and other developing countries, we're very grateful for these contributions, because they make a lot of difference. in terms of our abilities, especially now. I mean, we're all worried that with this ambition, with all the challenges in the world, with the conflicts and diversion of resources to other priorities for developed countries, that this may not happen. But we are pleased that many countries still came to the party. What we're looking forward is a continued commitment, because this is not a sprint; it's a marathon. We know we have a target of 8 years to to stop TB, and also on the HIV side as a public health threat. It's good that we've given ourselves such a short period so that we can push, and hopefully we will maintain this momentum over this next 8 years, and make sure that also in that period is not just the financial resources, but also that because what is important also, it's to allow countries the space to develop their own capacities with the assistance of this injection of this financial resources across what we have spoken about, creating internal capacity in terms of technical, professional skills, research, scientific skills, production. Because if this funding can contribute towards that, then it means actually beyond the 8 years, many of us will be self-sustaining. Not only can we have more certainty in terms of the defeat of these epidemics and pandemics, but also self-sustainability if we are allowed to also build our own capacity using this financial injection.
And to wrap up.
Thank you. I think Minister has said it well. Although we have not made the expected amount with the replenishment, I am very much encouraged, because with all the competing issues globally, this is a demonstration of the commitment to really fight these diseases, strengthen the health systems. But I think it's also a call for us to really, with this invested money, we need to really work on sustainably ending these diseases, but building systems so that we create sustainable progress, but also an assignment for all countries as well to really step up and increase the domestic financing. When we're saying the domestic financing, it's not just the government treasury, but also different sources of domestic financing that can complement and support and bridge this gap to achieve to where we want to go. Because particularly since we are talking about TB is still killing millions of people, and for me for my country, it's among top 5 killers. So it's really a key priority.
Well, thank you both. Thank you, ministers. I appreciate you joining us and appreciate your time. So I know you have meetings to get to, so I will let you be.
Thank you very much.
We have 2 panelists in person. We should have Carol and Jeremy. I can have them come up, and we'll have 2 more virtually. Hi.
Hi, Jeremy. Sorry.
Nice. Wherever you'd like. So we have Carol Nowina Nyarenda, did I get that correct? She's Executive Director of CTAM Plus in Zambia. We also have Sir Jeremy Farrar. He's Director of Welcome. And virtually with us today, we have Dr. Teresa Kasieva. She's Director of the Global Tuberculosis Program at WHO, as well as Sherry Vincent, who's Chief of the Infectious Diseases Division at USAID. So welcome, everyone. I want to start with the question that's on everyone's mind, which of course is the replenishment. It fell short. There were 2 countries that did not pledge, but the pledges could come in later as well. So what do you think of yesterday? Carol, let's begin.
Okay. For me, as somebody who is part of what we call the Global Fund Advocacy Network, we've been doing a lot of work from the beginning of the year. it's sort of a bittersweet moment because we're really hoping to get 18 billion or above. So falling short by less, especially somebody who comes from the TB community, which we always call is the orphan, the cousin of HIV, for me is really sad because then we might end up still getting less. But we are really happy because I'm from affected communities, somebody who's had TB as well. So we're really happy that at least the pledges did come in and we'll be able to move on. And we are hoping that the 2 countries that are remaining will be able to bridge that gap.
Jeremy, what are some of your thoughts?
I don't think I've got very much to add to that. Firstly, I would celebrate that actually a lot of countries have come in who perhaps haven't been part of it before, and I think that is a massive step forward, and then pay tribute to the leadership here in the United States of President Biden and bringing the whole Global Fund replenishment together, and indeed the whole team at the Global Fund. And then a number of other countries have also increased their pledges. So I think there is, at one side, a positive. There are 2 countries of which I hold a passport of one, but I'm not part, I should say, of the government, who are yet to pledge. And we should remember that the pledging moments are not, there's a jamboree around a certain day, but actually countries can continue to pledge until, I think, October. And I think we need to balance how we now work together to encourage those countries to think. Of the 2 countries we mentioned, I would also say politically, one is just got a new administration that is almost hours, if not days old, and the other one is facing an election very soon. So I think we should be a little bit patient, behind closed doors, have some of Lashita's anger, frustration, and in your face with a mask on. But I think we should leave these countries and we should try and bring them in.
Softly. Patience is a virtue. Switching over, Teresa, what are some of your thoughts?
Good morning, dear colleagues. It's a pleasure to join you today virtually. Of course, we would like to join also I think with Cherry and congratulate all of us, community working for 3 diseases with the successful replenishment, although we understand, Jeremy, that pledges will be continued. And luckily, I hope so that we will receive more funding. This is from the positive side, but from the side of our realities, the reality of TB community, of course, it will not be enough. Even with the successful replenishment, TB is receiving less out of 3 diseases, and it's clear for us that we should continue our advocacy and try to apply to other funders, try to find new mechanisms, innovative mechanisms to fill our critical and chronic gaps for TB. So that's all from us.
Okay. And Sherry.
Thanks. I'm happy to be here today, unfortunately virtually, but thank you to Devex for hosting this event. As part of the US government, I think, as was said, that we were all in. So really brought together a lot of the partners and countries to host the replenishment. And I think we will continue to work with the organizations and governments that have already pledged and those that are yet to pledge. So it's a good start, I think, as Jeremy said.
So Jeremy, actually coming back to you, sorry to mean to surprise you there. You've been a vocal advocate of vaccinating low to middle income countries against COVID, even as the pandemic fades from the headlines. That, of course, has yet to happen, and COVID has really pushed some healthcare systems to the breaking point. At the same time, pandemic has showed that investment in TB can be a useful defense against airborne diseases. So can you talk a bit about the impact, both good and bad, that COVID has had on TB prevention and treatment?
Yeah. TB is in some ways a sort of, as many people in this room know, a sort of weather vane of how a health system is working because of the complexity of diagnosis, as we heard from Jackie earlier on, the complexity of treatment, but also the integration of health systems, of top-down, but also essential community-led support for it. So it is a sort of, but it's also incredibly vulnerable. And COVID has undoubtedly put back, and will continue to put back, TB TB is on a precipice the whole time. If you give up on it for a year or 6 months in a country, a region, or the world, it goes back. And it's not going to disappear. TB is with us forever, and we should plan that this is a long-term approach. But TB is also at risk of conflict, as we heard earlier. The conflict in the Ukraine at the moment, the tragedy of the war in Ukraine, will push back tuberculosis across all of Europe and Asia. The conflict in parts of Africa will push back TB control there. So the world going forward over the next decade is not going to be a smooth place. We've got economic hardships, we've got political insecurity, we've got increasing tensions geopolitically. We have to think that TB is going to exist in that world, not the perfect world. And so if we don't invest, Global Fund, Stop TB, all of the TB programs, and if we don't make this a more horizontal system rather than a series of vertical silos, then I'm afraid TB will increase again, drug resistance will increase, and the burden of TB globally will go up, not down.
Kara, likewise, can you give us some insights into how COVID disrupted your work in Zambia, and also have there been any silver linings?
Okay. So I think just as Jerry has said, what happened in most cases is that community activities were stalled around advocacy, communication, and social mobilization. People were not able to go out into the community, and this also increased the stigma, because if you had a cough, people were worried to go that maybe what I have is COVID, and they were afraid to go to the facilities. And because of the lockdown, people were in the communities, so most of the treatment supporters were pulled out. The other problem was that because then you're not going to the hospital that often, the reviews are less. Even though people were given more medication, then there's a chance of, if you miss your treatment, then you might have resistance. So the worry of having multi-drug resistance was also really high. But then in Zambia, we had also brought up this situation to sort of curb the MDR TB, where they brought in retired nurses to come and support the system at the facilities. Unfortunately, because most of those nurses who were brought in were older, so they were pulled out because of, the worry of COVID on the older people. So again, that also brought the problem. The other issue which I alluded to, most of the equipment, like the Gene Expert, which is the main equipment that we use for TB, was moved to COVID. Some of the wards that we have that were meant for TB, those are the ones that were used as COVID centers. So a lot of resources were taken from that. But then I think the silver lining, like you said, was I think pandemic preparedness. A lot of things have changed now. The system is better. And then also we came up with things like eDots, where our community volunteers could still support their patients by using WhatsApp calls and watch the person take their medication in the first 2 months of treatment. The other part was, as a country, the Ministry of Health also put up weekly meetings, TB situation room, so where provincial coordinators could speak together so that if there's a problem, it's caught within that short period. The treatment supporters were also given protective wear for them to go out in the community. So they had masks, they had hand sanitizers and everything for them to continue with the work. But the other one was also, we came up with a campaign in Zambia that was called Moving Towards, in 2020 was moving towards 45,000, and then 2021 was moving towards 55. This was a campaign to deliberately fund the missing cases. So this was done by the country, the treatment supporters, communities, and everybody was involved. So there were all these campaigns that were put in place. But then people became innovative, and then, it made things a little bit better. For me, what was really exciting, especially around the eDots and then the pandemic preparedness.
Now, Sherry, switching gears a bit, USAID Administrator Samantha Powers pledged that 25% of the agency's funding would go to local partners within the next 4 years. As of last year, according to Devex's calculations, it was about 6% of the budget went to local partners. So in regards to USAID's TB efforts, how is it supporting locally generated solutions, and how has that support ramped up since Administrator Powers' announcement?
Yeah, thank you for that. So I think this is a shift that we have been starting long before. And, obviously governments are the domestic funding is the biggest source of funding for TB in many countries. And so there is already that support there. It's not enough by far. So we've really been pushing in terms of making sure that we have locally led support. And we've been doing that through our support and increased support to the civil society challenge facility. And we've increased sevenfold our funding to that group. We also we've way surpassed the 25%. So in Africa, we have almost 58% of our country level funding is going directly to local partners. So I would say it's on its way to being it's definitely majority led local partners. And then overall, it's at almost 39% if you look across all of our countries. So we're really pushing this agenda, and it's very important to make sure that civil society and communities have a seat at the table, that they actually are involved in the development with governments and other partners. And we're trying to help to support that. People like Carol, they're doing amazing work. And I think in COVID, we really saw the benefit of that work, because they were the only ones that actually could adapt to the situation on the ground. They knew what needed to be done to adjust for those issues. They were working with the communities. They were right there with them and helping them through it. And so I don't think that we could have, I think that Zambia had a very small decline in case notifications, and it was really due to the communities and the work that they did in COVID. And I think them having the resources to be able to do that and adapt there in the moment, in the situation. And as Jeremy said, we're seeing more of these kind of situations. We need to make sure that they're empowered to do it, and we're moving in that direction. So definitely in the forefront of Administrator's Powers commitments.
Thank you. Now, Teresa, there's, as you know, quite a bit of work that needs to be done. It's an understatement to achieve the 2030 SDGs on TB. What do you see as some of the key innovations that you're excited about, including new treatments and diagnostic tools that you're keen to see scale up? And on the flip side, many TB medications currently being used in low and middle income countries have some severe side effects. So can you talk about the good and the bad in terms of treatments?
Yes, for sure. And let me start from kind of not bad, but the reality. Our reality. TB is a complex disease, especially its drug-resistant forms. It requires a long treatment with a combination of drugs and very serious drugs. They are not sweets. And of course, when you're using them in combination for a long time, you could expect side effects, even if you're carefully managing and monitoring and providing support during the treatment. So, but in the same time, from the positive side, we must say that TB is still a preventable and curable disease. And in the past several years, we can see really dramatic scale up and appearance of new effective medicines, tools, diagnostics, which can help significantly. First of all, shorten treatment, and we can see already, if you look at our latest recommendation, treatment for drug-resistant TB shortened 3-4 times. And now it could be effective, safe for 6 months. Of course, 6 months is still long, but if you compare with 24 months previously with the painful injectables, it's much better. We can have much better options for TB preventive treatment, 6 times shorter. 1 month preventive treatment cost, 3 months preventive treatment cost, much more options, different, safer, fully oral. We are not recommending painful injectables with side effects anymore. So we have diagnostic tools that we're strongly recommending as rapid molecular tests to use from the very beginning as initial test. So opportunities are there, but unfortunately, uptake is still slow in the countries. Not all high TB burden countries even are using this opportunity, and this is concerning. Of course, we understand the reasons are different, and reason number one, I would say, lack of prioritization at the highest level of senior management and understanding of importance of introduction of these new tools and medicines. Of course, second reason is a chronic lack of funding, and you can't use these options if funding is not available. Of course, COVID impact made the situation even worse, but in the same time, these opportunities make treatment possible in the situation when services has been disrupted, and it could be provided home-based fully under the video control, as Carol mentioned, gave very good example how it could be provided. So opportunities are there much better, and we are expecting, by the way, in the coming years, we already have this information, further shortening and improvement of the treatment options, appearance of new even point of care tests, and this is reality, this is coming, and we will be happy to update our guidelines and propose them to people with TB as fast as possible.
Thank you. Well, and similar question for Carol and Jeremy. Are there any particular innovations that you would like to see scaled up and made available globally? Carol?
I think, like I mentioned, the e-dots was really, really important because most of the people, even in the global south, have phones, especially the Android. So what we did, like with the ones in the deeper communities, if they had the ordinary phones, we just supported with Androids. So I think the e-dots was important, but the other part that we did was we had what we call information desks at facilities, where people would now wait at the gate. If you're not able to go into the facilities, you have former TB patients sitting there who would then give you more information, somebody who's been on treatment, and just to sort of even handhold the person and go into the facility with them. So that is one of the easiest ones, I would say.
Jeremy?
Yeah, having painted a pretty bleak picture geopolitically and economically over the next decade, I've never felt, and I've a doctor working for 20 years in Vietnam, and TB has been at the heart of much of my own work, and I have never felt more optimistic about what can happen over the next decade. We've heard from WHO here about diagnostics and treatment, and it needs to be pushed further, but the interventions we have now are better than anything we've had before. On the vaccine side, I do believe that in the decade that we're in at the moment, we will have a publicly available, or more than one publicly available vaccine. What we should be doing today is thinking, if we arrived there in 2027, 2028, or 29 or 30, what do we need to have in place now in order to deliver that, not in 2040, but in 2029 and 2030. And I think what that behoves all of us in the TB community, and I'm a part of the TB community as well, I'm also infected as well. What we need to do is put aside our conservatism. It's quite a conservative TB community. We need to put aside the fights that say we don't need new interventions, we just need to do what we're doing now a little bit better. And we need to be willing to embrace innovation, and we need political systems and funding that would allow that innovation to get to patients quicker. And I think there are lessons to be learned from HIV, yes, from COVID, and certainly from malaria as well. Just one caution on comparing TB and COVID. We didn't get a COVID vaccine in a year. And my good friend, the Minister of South Africa, says, well, that was an investment over 20 or 30 years in basic science that allowed us to have mRNA vaccines. And they're the only two vaccines we've ever had on mRNA. And to think that within the next year or two, we will suddenly have mRNA for vaccines for HIV, TB, malaria, dengue, and everything else, I think is, even for me, overly optimistic. So let's plan with communities at the table from the start, designing what we would need if we had the innovations that I'm optimistic that we will have. And let's do that today.
Excellent point on the COVID vaccine. That's often gets overlooked. So thank you for bringing that up. I wanted to open open it to the floor for any audience Q&A. If you have a question, please give a brief introduction. And I believe we have some microphones. We do have a question over there. If someone can pass a microphone. Mm-hmm. I have two in the back there. Gentlemen. Yep.
Yeah, hello, thank you. My name is Louis Schrager. I lead TB vaccine development at IAVI. I would just like to begin by thanking the organizers for convening this important group, and thank you to the speakers as well. So my quick statement that's going to lead to my question. You know, my focus is on TB vaccine development, and we are at an inflection point at TB vaccine development with one vaccine already in phase 3 for preventing disease in adolescents and adults, and 2 more really knocking on the door. That's the good news. The challenging news is that for the 2 that are within the next year or 2 or 3 ready to go into phase 3, the combined cost of those studies will be in the approximate neighborhood of $1 billion. So the question then is, I mean, I think it would be tragic if after the years and years of development that you know, we spoke about leading to this point in vaccine development, that we'd spend more time raising the funds than actually conducting the trials. How can we accelerate the opportunities to raise these kind of funds to make sure that these vaccines are given a fair shake in phase 3?
Thank you. Well, we have a full house. Does anyone want to begin? Jeremy?
It's a great, if we don't answer this question, we won't have the innovation this decade. And I think the critical element is for all of us in the TB community to look outside TB and learn lessons from other places that have done this much better than mostly does, actually, to be honest, the global health community. Look at the way cancer trials are organized around the world, or trials of diabetes, or some of the non-communicable diseases. Look what happened in the recovery trial and the solidarity trial during COVID. It was pragmatic, it was much cheaper, it was more data-driven rather than old-fashioned CRO-driven expensive clinical trials of the type you do. And then you have a platform that would plug and play. Whichever vaccine came along could plug into the same platform in a distributed way around the world with harmonized data that allows you to compare between vaccines and gets you to an answer much quicker. We have to transform the way we're doing clinical trials, because it is not affordable to be costing at the levels you said and have the innovation that we need in the time that's needed.
And did anyone else? I want to give our virtual participants any thoughts on the question in terms of vaccine affordability.
I may use this opportunity. Thank you for question. And I would like to inform you that TB vaccines agenda is becoming a big priority in the organization, and the Director General, Dr. Tedros, is himself very strongly committed to lead and advocate for the development of new effective TB vaccines. We are planning to organize early next year a big forum with engagement of key stakeholders, and really to receive clear commitment and to agree on clear and soonest actions, how to push forward this agenda. It's possible, and we should learn from COVID-19 experience. I agree with Jeremy, with others who can learn from other experiences, and it's time. If we will lose this momentum, another will not come soon. So that's why with optimism, reasonable optimism, we are planning to move forward. Yes, there is one vaccine, the most promising, but also there are around 14 other vaccines at different stages of the development. And also we should invest into the fundamental research. We can learn and see how impressively fast moving HIV community, we can do it. Thank you.
And I believe we have, oh,
Yeah,
Sherry,
maybe I
sure.
could just add. Yeah, sorry. I know I'm online, but I think, you know, we're not that conservative, I would say. If you look at some of the people on the panel here, I think, and the TB community, I want the vaccine tomorrow and hope it's somewhere been researched in the lab somewhere. But I think on the access front, you know, we have a new research project called Smart for TB. And I think that is something we will focus on, what Jeremy has said, working on access, because we want to be prepared. So I think that's something we can do. We don't have the resources for the $1 billion. at least not appropriated to us. And so I think that is a question of how do we come together and, work with countries. I mean, there's a lot of capacity out in high burden TB countries as well in research, and we need to mobilize those funds as well in those platforms. So it's a dire issue that we do need to solve.
And I believe we have another question right back there.
Hi, everyone. My name's Robin. The next 12 months could be really critical moments for the TB community and making advances. We've got the HLM coming up. We've got new plans coming out of the Global Fund. We've got new tools like a shorter 6-month all-oral regimen for drug-resistant TB. So there's so many opportunities that the TB community could be leveraging to make massive advances in the next 12 months. So I'm curious how we're going to do it. One of my questions about internal TB community coordination, are we coordinating around the HLM already? Are we starting to talk about TB within the country coordinating mechanisms of the Global Fund, et cetera? And then another question would be, how are we coordinating externally? There's also going to be a high-level meeting on UHC, a high-level meeting on pandemic prevention, preparedness, and response. Are we tapping into those spaces to make sure that TB is present and visible across all of those aligned and relevant advocacy spaces?
Thank you. So internal, external coordination ahead of the high-level meetings. Yes.
Yeah, I can start and say 3 things. I'm aware of the time, but this is a very good question and cracking the nut. So in terms of internal partners coordination, as we had some experience from 2018 where actually we were able to come all together. So with the colleagues from WHO, we are having together the task force of the partners that will have regular engagement and conversations, and will also go ahead into developing, or discussing the key asks. But very important as well, and I'm happy as this, is that we will identify also a civil society organization to be able to hold together all the civil society partners. And that will be an organization which is not a Stop TB. We will just fund that will be able to coordinate with everyone from the civil society to ensure that the hearing and the participation is there. And I hope we are doing that together with also the WHO Civil Society Task Force. And very important, I want to flag on something it's around coordination, but it's also around flagging what is happening or not. I'm happy to say that we are funding the colleagues from communities and civil society to develop the report called Deadly Divide 2. The Deadly Divide, and that's happening now. And I will invite everyone to participate in that. It will take, the Deadly Divide is the divide between the commitments and what was achieved. And it's a deadly divide between that. It's a deadly divide between North and South. It's a deadly divide between people in the countries, political and so on. And that will be also led by civil society. And we want this to become a very strong accountability tool coming from the people, your people, the We Are TB people, the TB people, the advocates and activists at the country level that are invited to provide support, inputs, and comments into this. So that's about the internal coordination, and I know Teresa and so on we can add more. On the outside part, you're absolutely right. On the UHC, I think we were engaged. They have a task force in which they invited TB as well, UHC. The PPR is very new. In terms of being framed, that is going to happen. But we have some great collaboration there because it's led a lot by I know that it's a South African-based initiative, so we were discussing with the minister how TB can be part of that. I think the most important is between us to be united and to be shoulder to shoulder. And in crafting the messages, we will find the entrances in coordination.
Mm-hmm. Thank you. Well, unfortunately, we are running out of time, but obviously there's a lot to talk about. Devex has a large content series called Talking TB. I do encourage you to check it out. It has a lot more information. I want to, of course, thank our partners, Stop TB Partnership, our co-host for today. And coming up in 15 minutes, we will have a session Unlocking Sustainable Finance for Nature-Based Solutions, which I'll be moderating. So I know everyone will stick around to join me. So thank you. Thank you to our panelists.